Hello, my name is Yunus Al-Madfa'i. I am PGY1 internal medicine resident at West Side Regional Medical Center and Northwest Medical Center. Today I will be showing a case of COVID-19 pneumonia complicated by fulminant myocarditis and a left ventricular thrombus in an obese but otherwise healthy young man. Introduction. Severe complications of COVID-19 pneumonia can be seen in all age groups, but with greater incidence in elderly population and those with certain comorbid conditions. This article presents a case of fulminant myocarditis with severely reduced ejection fraction and left ventricular thrombus in an obese but otherwise healthy young man. A case description: 30-year-old obese man with body mass index of 32.4 who presented to the ER on account of fatigue, cough, fever, shortness of breath, and orthopnea. On examination, bilateral pedal edema and tachycardia was noted. Significant lab findings include absolute lymphopenia, elevated BNP D-dimer, and liver enzymes. The troponin was minimally elevated but remained flat. Creatinine kinase was normal. COVID-19 PCR was positive. Chest X-ray, as you see in Figure 1, the picture on the top, revealed diffuse multifocal bilateral airspace disease. Two-dimensional echo, Figure 2, as you see in the picture at the bottom, suggested severe diffuse hypokinesis with an ejection fraction of 20% and 16 mm times 14 mm left ventricular thrombus adherent to the apical wall. The patient was diagnosed with COVID-19 pneumonia complicated by fulminant viral myocarditis and left ventricular thrombus. He was treated with IV Lasix along with beta blockers, ACE inhibitors, and aldosterone antagonist. He was also treated with therapeutic dose anticoagulation, remdesivir, IV steroids, and convalescent plasma. Cardiac catheterization was deferred due to active infection. He was discharged after 14 days with an ejection fraction of 20% on guideline-directed optimal medical care for acute compensated heart failure, reduced ejection fraction, and full dose of anticoagulation. The patient was readmitted to the hospital 3 months post-discharge due to shortness of breath. Repeated cardiac echo confirmed persistently low left ventricular ejection fraction of 20% with dissolution of left ventricular thrombus. Cardiac catheterization was done, which revealed no obvious obstruction or thrombus. In the discussion, myocarditis has been established as a possible severe, albeit infrequent, sequela of COVID-19 pneumonia. The thrombus formation seen in this patient can be attributed to cardiac hypokinesis and a hypercoagulable state sometimes noted in COVID-19 infection. Obesity is the only comorbid condition identified in this young, healthy patient who developed a severe complication from COVID-19 pneumonia. It would be imperative to monitor such patients closely with serial echocardiograms and/or cardiac MRI with consideration for life vest and implantable cardiac defibrillator replacement for a primary prevention of sudden cardiac death. In the conclusion, there is insufficient evidence to suggest a recovery of cardiac function after viral myocarditis due to COVID-19. The severity of cardiac dysfunction and its correlation with the severity of acute COVID-19 infection is yet to be established. This case suggests obesity as a risk factor that can predispose a young and healthy patient to severe complications of COVID-19 pneumonia. Thank you very much and have a great day.